Thank you so much. I appreciate the organizers for inviting me here today. Good afternoon, everyone. I'm not a clinician. I'm a neuroscientist, and that my doctorate is in neuroscience, and I did electrophysiology research in animal models. But since then, my work really has been in legislative affairs. I think a lot about policy and regulatory governance for health technologies, particularly brain health technologies. So today I'm wearing the hat of an ethicist, and we're going to talk about what I mean when I say rehabilitating epistemic agency in cases of covert consciousness through BCI-enabled communication. So the organizer kindly gave my bio, so I won't go over this again. I don't have any disclosures. This talk is not a research talk about anything I've discovered about covert consciousness. It's not a methods talk about techniques we can use to assess covert consciousness. This is an ethics talk about what we, as clinicians, researchers, and scholars, should be trying to do for these patients and why. It's a talk about the ethical harms that we risk mediating if we shy away from the moral obligations that arise in this very special group of vulnerable patients. So I'd like to explore here with you the ethical tensions in covert consciousness, namely this question: how does the unmasking of hidden sentience in a vegetative state patient reorient an ethic of care? This is the central question. Against, I'll make some normative claims about prudential goods and our moral obligations to facilitate those prudential goods. So what is covert consciousness exactly? Let's go back to one of the principal landmark studies, now many times replicated, in which covert consciousness was unmasked in a case study. In 2005, a 23-year-old female survived a catastrophic TBI pursuant to a car accident. After 5 months in neurointensive care, multiple independent bedside examinations by a panel of neurologists led to a diagnosis of vegetative state: awake, non-responsive. The patient has sleep-wake cycles. She can blink, grimace, yawn, grind her teeth. Her eyes may roam the room. However, this motor activity seems to be completely unlinked from volitional control or responsiveness to stimuli. Responses to commands such as follow my finger with your eyes, squeeze my hand, wiggle your toe, go unanswered. Such was the case with this 23-year-old woman with severe TBI. The longstanding assumption in cases like these is that the person is awake, but their personhood, their self, is not there. However, Adrian Owen and colleagues hypothesized that it could be possible for a person to have a brain injury that decouples the brain from affecting motor outputs while they still retain sentience. If this was the case, you'd expect to see brain activity consistent with command following in the relevant areas, even though the patient could not move. So this is what they tested. Here, we're looking at bold signals, fMRI, using oxygenation of blood as a proxy for neural activity, where they asked the patient, imagine playing tennis. And here we're seeing activity in the supplementary motor area, similar to matched healthy controls. In another trial, they asked the woman to imagine moving about the rooms in your house, and they saw activity in the parahippocampal gyrus, the posterior parietal lobe, and the lateral premotor cortex, similar to what you see in a healthy group of matched volunteers. In a media interview, Owen remarked about the results, and I'm paraphrasing, "We were ecstatic. She cooperated fully with what we commanded when we commanded it. She wasn't vegetative at all." And the results, they wrote, those diagnosed as vegetative, sometimes also called minimally conscious or locked in, may be able to use their residual cognitive abilities to communicate their thoughts, to those around them by modulating their own neural activity. So to some, covert consciousness is a state of residual wakeful awareness following typically severe TBI or neurological disorder that evades routine bedside neurological assessment or even standardized neurobehavioral examination, GCS typically 3 to 8. Patients with covert consciousness have preserved sentience, but are incapable of self-expressing through volitional motor control. They are awake and they are aware, but people cannot tell that they're in there. However, if you were to look at their brain activity in response to task-specific commands, spoken commands, as observed via fMRI and EEG, most typically, you would see evidence of sentience. Last year, actually, a recent multinational study led by Mass Brigham General, in which about 350 patients across 6 sites, including vegetative and unresponsive wakefulness syndrome patients, taken from critical care units, nursing homes, rehab centers, and private homes, were assessed either using fMRI, EEG separately or both, to assess for evidence of CC, covert consciousness, using the motor command task, imagine opening and closing your hands. And they found that nearly 1 in 4 so-called vegetative patients showed evidence of at least some level of awareness, that they could understand the command, they could follow the command at the appropriate time, even though no motor output was possible. So it's one thing to read a clinical definition of this extraordinary condition. It's another to hear it described from those who have survived it and come out the other side. Marcus Pistorius is a young man from South Africa who in 1975 suffered severe tuberculosis meningitis and progressively fell into a vegetative state. He later reported regaining awareness sometime around his 16th year, after 4 years, despite no volitional motor output. His covert consciousness remained undetected for 9 more years before he finally was entered into intensive neurorehabilitation, where he eventually nearly made a full recovery. He wrote a book called Ghost Boy, which is a really powerful read. I highly recommend it. He says, "Again and again, I'd ask my unruly limbs to make a sign and show someone I was there, but they would never do as I asked. I was completely entombed. The only person who knew there was a boy within the useless shell was God. For so many years, I was a ghost. I could hear and see everything, but it was like I wasn't there. I was invisible." Here's another case. In 2013, a 19-year-old US man suffered an anoxic brain injury and diagnosed as vegetative state. He recovered after a few months. And when he recovered or emerged from his disorder of consciousness, he reported preserved awareness during his disordered state, including memory of conversations and recognition of faces and objects that he had only encountered while asleep. So they tested this and showed him 5 faces of staff and 5 similar faces, and he got 5 out of 5 correct, and the same with 4 out of 5 objects. He could even recognize the voices of clinical coordinators who had worked with him. He said, "I felt trapped in my own body. I couldn't talk, I couldn't react. It was like being half asleep and frozen." I'm giving an example of these miracle cases of people that made full or near full recoveries, because these are the ones that give quotes to the New York Times. But my arguments about ethical stance in covert consciousness are principally concerned with those who are in a chronic or persistent state, for folks where residual awareness isn't necessarily a precursor to successful rehab, but these are folks who may live in this liminal state on an ongoing basis. So we care about our moral obligations to them, not because they're going to get better, but precisely because they might not. So this was the question that really sort of drove my interest in this topic when I was looking through the research and noticed, okay, we've identified that there's someone in there. There's someone in there. What are we asking them? Open and close your hand, follow the tennis ball, walk around your house. Are you in a hospital? Do you recognize this picture? Focus on the circle, ignore the square. What we're not asking, at least in the research literature that I found, is there something about the environment that is causing you distress? Is there a different way you'd like to be positioned? Would you like to go to a different room or go outside? Person A is here. Are you okay with this visitor? Your mother says she loves you. Do you understand? Would you like to be ministered to by a chaplain? So this is my claim. Patients with covert consciousness are moral persons with interests in how well their lives are going for them. But without functional brain monitoring, they cannot express information about their subjective experience of themselves. Although a lot of great work is ongoing to characterize the phenomenology of covert consciousness and advanced brain imaging communication methods, and they're considering implications for clinical prognostication, rehab, and decision-making capacity, in addition to all of those lines of research for detection and prognosis and rehab, we're calling for parallel efforts to facilitate well-being in a person with covert consciousness indexed to their current circumstance of disability, doing so by acknowledging them as an epistemic agent. Okay, what is an epistemic agent? It means to be the authoritative source on what it feels like to be you. So they're sentient. They have an experience of the self. They have a sense of what it is like to be them. This means that they are an authority on their own psycho-emotional states, about what physical sensations feel like. They have preferences about the environment. And they also may have preferences about this. What features of their morally valuable lives are meaningful and fulfilling, comforting or distressing, hopeful or despairing. Going back to the young man, he said, I remain in so many ways a blank page onto which they write their own scripts. Frustration rose up inside me so often because I was constantly reminded I couldn't determine my own fate, even in the smallest of ways. It was terrifying. What really got to me was the complete and utter powerlessness. Every single aspect of your life is controlled and determined by someone else. They decided where you are, what you eat, whether you sit or lie down, what position you lie in, everything. So here's my normative claim. When evidence of covert consciousness is present, and when communication enabling neurotechnologies are available, ethical care orients us to leverage those technologies towards proportionate, welfare-oriented inquiry into their subjective experience as a critically important prudential good. This obligation does not depend on their prospect of recovery. This does not grant decisional autonomy. This does not collapse into end-of-life decision-making. This is grounded in welfare, disability ethics, epistemic justice, that is to say, being acknowledged as a knower of one's own experience, and avoidance of relational harm. So I'm going to make 3 bioethical arguments to bolster this claim. First, a welfarist framework of care ethics says, okay, we have this intervention, restoring communication. Let's assess it based on how much well-being it promotes for the person relative to their current circumstances. I would argue that restoring communication is extraordinarily important, probably one of the most important things you can do to improve their quality of life. Again, I'm not talking about restoring decisional autonomy or supplanting surrogate decision makers. I'm talking about the sorts of everyday, what can I do to make your life better right now? What is important to you today? Preference questions that are central to goal concordant care. And yes, this self-expression might reflect disordered thinking, confusion, disorientation, agitation, by virtue of the brain injury that got them in this condition in the first place. But that does not negate the relevance or the moral significance of their self-report. Persons with dementia, delirium, psychosis also experience delusions or disordered thinking, yet we routinely recognize their interests in pain relief, comfort, environmental tolerability, and relational presence. We ask, are they hot or cold, in pain, overstimulated, distressed? We do so not because their beliefs or reports or perspectives are always aligned with consensus reality, but because their experiences are relevant to how we orient towards their care. Not being offered the opportunity to communicate held thoughts about your preferences, interests, and values when such technology is available is misaligned with our ethical obligations to beneficence, to do good. Under principalism, the 4 principles of bioethics, autonomy, beneficence, non-maleficence, do no wrong, and justice, failing to act presents the risk of ethical harms, including epistemic injustice, which is to say, I know that you are a knower, but I'm not going to acknowledge you as a knower. I will instead supplant my inferences of what I think it is to be you, rather than asking you what it's like to be you. That's epistemic injustice. Argument 2. We recognize a duty to respect the dignity and moral personhood and epistemic agency of a very disabled patient. For those who have capacity to self-express, we acknowledge widely that assistive communication devices are priority disability accommodations for nonverbal patients without a disorder of consciousness. Similarly, a bidirectional communication tool about subjective states in CC is a priority consideration for this preference concordant care, whether rehabilitative care or comfort care in disorders of consciousness and covert consciousness. I'm not arguing that the patient who by definition has a severe brain injury should be considered as having autonomous decision-making capacity with respect to important care decisions. Rather, I'm saying yes, and that epistemic authority, again, who gets to say what it is like to be you, can be shared between them and the surrogate, that they can at least inform considerations about their care. Going back to the case of Martin Pistorius, who lived with hidden sentience for nearly a decade, he writes, "I traveled beyond what medicine understood. I was lost in the land where dragons lie, and no one could rescue me." He described extreme loneliness. Humans are relational. Social participation and personal communication are prudential goods for well-being. Restoring communication, however limited it might be, can therefore mark a partial return to social life. To be able to acknowledge others in role-sensitive contexts, this is my spouse, my son, my daughter, my brother, my sister. That acknowledgement, that relational agency is also critical to our welfare as social beings. So for a person with a disorder of consciousness or covert consciousness, communication can mitigate a profound sense of social isolation. Absent this, their identity can collapse into total alienation. Even sparse, minimal communication is meaningful to restore social presence. The patient goes from being just a patient, an object of assessment, an object of observation being acted upon, and the person can communicate in the context of treasured social roles. It can allow the person to communicate in community, in the world of social ties that continues around them. They can be included again. So I'll go through this kind of quickly just to acknowledge that, of course, it's more complicated, right? Signal misinterpretation is a real thing. How do we validate these outputs? My answer to that is that what I'm proposing are reversible, low stakes, experientially meaningful asks about well-being. You know, things that are relatively, may seem relatively trivial, like what game should we put on? But actually going back to the case of Martin, he described that in his care unit, they played the same children's program every day for a decade, and it caused him a lot of psychological distress, where even today, in his wakeful state, he can't hear the theme song anymore. He goes into like a panic state. So these things are minor, but when that is your entire world, your entire universe are the four walls of that room, what plays on the TV all the time like really matters. About high stakes decisions. Yes, substituted decision-making with team and caregivers remains essential, remains primary. We proposed shared epistemic authority that can inform preference concordant care. What about if they're incoherent? That's fine. It's the sentience and not the rationality that grounds our need for moral courage to ask about subjective states, even if the answers are confusing to us. Chanel, this is really expensive. We don't have fMRIs and EEGs running around to, put on patients' heads. I completely understand. This is more about a call for an ethical orientation, increased ethical sensitivity, that this is a important and attainable goal, not a nice to have, not a, oh, we'll get to it later, or like, yes, sure, we know it's a good idea, that we are committing real moral harms by not doing it, not making best efforts to do it when we can. Imagine if this were you. What would you want people to do for you? So this is my summary slide pretty much. When we have reason to believe a person is conscious and what tools exist that may facilitate communication, albeit imperfect communication, our moral sensibilities should be challenged by their muted voices, rehabilitating their epistemic agency, allowing them to tell their story about what it is like to be them, is not really about rescue or cure. It's about the duty to inquire, how is life going for you? What can we do to advance a better experience of that life? In order to do this and to improve their lives in ways that are relevant to their own subjective experience of themselves, we have to know them. And to know them, you have to ask. You have to ask questions that matter. What is it like to be you? What can I do to make it better? A research need that emerges from this call is a validated well-being instrument or assessment to help caretakers, loved ones, and researchers in a dialogue about preference concordant care using BCI. So we acknowledge that even under conditions of extraordinary disability, this patient remains a knower, a holder of interests, a relational being, someone whose life has moral significance. So back to my central question, what do we owe them? You must hear them and know them. This is a quote from Stroke Survivor. Make eye contact with me. I am in here. Come find me. Thanks to my collaborators and people who supported the abstract upon which this talk was adapted. Thank you.
Thank you. Any questions? Oh, he's faster than me.
Fantastic talk. We talked about what keeps people up at night. Convert consciousness definitely keeps me up at night as a rehab doctor at a 500-bed Lagoon nursing home. What ethical obligations do we have for finding patients with convert consciousness?
Yeah. The latest clinical guidance from 2018, Giacino et al. And colleagues, for the first time, I think in that year, recommended that if someone was behaviorally unresponsive, but yet was showing, relevant neural activity through these functional observations, that there wasn't it's not a duty of care to continue performing those assessments, but rather the doctor and the research team may continue using these assessments to try to determine prognosis or how likely that person is with continued intervention to perhaps emerge into lighter and lighter stages. They also said in the text that they didn't feel there was yet enough clinical evidence to support this becoming like a routine part of the care flow because most patients will continue to be unresponsive, and it is quite resource intensive. And so I'm curious myself, but the evidence sort of threshold or evidence burden would have to be for us to get to that question of knowing, like, when do we really need to begin to make these tools available for the many, many thousands of people, inpatient and outpatient, that might be sentient and we're unaware.
Lawrence?
How does, well, let me rephrase that. Does our moral obligation differ for those patients in whom we can't detect sentience, which could be there or not?
So absence of a response remains ambiguous because, attentional fatigue, the care environment is lousy, is noisy rather and loud. Perhaps the person heard but didn't quite understand the instruction. And so your question is, what is the distinguishing sort of ethical obligation for we know versus we don't know? I think for those where we know, there has to be a real concerted priority effort to attend to their subjective quality of life. They have an experience of their world, but are unable to make any modifications to it. They can only respond to questions posed to them, yes or no, but they can't proffer, any thoughts themselves. And so there's this huge sort of power imbalance. So I think that really emboldening the family who may know them the best to think about how to make their care environment as comfortable as possible would be really, really important. I also think that being mindful of the conversations you're having around the patient. Martin described hearing his mother say to him on a really bad day, because she quit her job to take care of him full time, and it was a very stressful time for the family. But she said to him, not knowing he could hear, "I wish you would die." And it really tormented him. He later forgave her because he said, I wasn't able to tell her how much I appreciated her. And then I was so thankful, he felt guilty that he was a burden, but, that's really awful. And so I think maybe we can also be sensitive to, if you're unsure if they're there, just act with kindness, because you never know.
Great talk, Chanel. I mean, I think it's really good that we have a group now that's working at the Weil, really thinking about these issues, because there's things that are happening now rapidly that are going to change. There's actually lower tech ways to start looking at some of this. So Eddie has a grant funded where we're going to be trying to look at some of this in the ICU. Also, some of these early signs that we see, I don't know whether he shared with you, but some of the EEG signals that we see are actually predictive of those who will wake up. And so I think because these things can be very troubling, and I could see how quiet, everybody was getting listening to this, because we worry about this, because we're in the acute phase of this where, we all worry about what's happening. And I've worried about this for a long time. What I can say is that, of the patients that we've studied, they actually they either get better, or oftentimes the families are letting them go. So, I mean, we're not necessarily making a ton of vegetative patients here, and I think what you get to see is that subset of those that are never waking up. And so it's really challenging to figure out what to do here. I really believe that what's happening across the country now, which is because I think these things are so troubling for us to think about as humans, is, well, the easy thing is just don't do anything and let them die at 3 days. Then that just kind of like, but what we've seen is that when we've looked at patients within the network where they were aggressive about early withdrawal and those that weren't, that we've let a lot of patients go that could have actually recovered. So ethically, it's really, really hard. I think all of us worry and we lose sleep. Hopefully some of these tools will help us make better decisions, because, some of the patients I've taken care of now are out like 20 years. They're really, really grateful because they've had families and, they've done things. And I think in other areas of medicine, we are still doing a tremendous amount of stuff for people that will never, ever recover. And people keep on saying, well, we're doing it because one day it'll be different. Well, I mean, in this field, it's a never day for most of these people. So I know it's a struggle. And I think one of the things I'm taking away from this is that we've got to do a better job bringing those patients back. I mean, like what you saw here with the spinal cord injury patient. I mean, we need to bring more of these TBI patients back as well, so that you can see what's actually happening to them long term. But Chanel, I'm really glad you're out here. And this is an important area that we've got to stay working on.
Okay, any other comments, questions? Thank you, Dr. Matney.
Yeah.